Good afternoon, and welcome to this month's gathering of the Northern Virginia Health Policy Forum. My name is Jim Scott, and I'm the President and CEO of Applied Policy. I'm also the founder of the Northern Virginia Health Policy Forum. The purpose of the Northern Virginia Health Policy Forum is to bring people together with interests in public policy and in healthcare. We work a lot on rules and regulations. The Northern Virginia Health Policy Forum started off in Alexandria, where I noticed that there was more than 50 associations, and we were all reading the CMS rules and following legislation, but we weren't really, there was no forum to gather to share ideas. So we started this off as a luncheon series, and then when COVID happened, we moved virtual, and that's enabled us to extend our invitation outside of Northern Virginia. So thank you all for joining today. I'd also like to thank the Alliance for Aging Research. I'm chairman of the board of the Alliance, and grateful to have Michael Ward here today, who is an integral part of putting together our very esteemed panel, who I'll introduce in just a moment. This afternoon is Medicare's 52nd anniversary, and we're discussing the challenges that beneficiaries face in affording drugs under the Medicare program, and they're specifically under Medicare Part D. We'll also take a look at how key proposals under consideration could impact the Medicare Part D program and patients. I'll start off by introducing our panelists, but for you, the audience, please make sure you're on mute when you don't mean to talk. Otherwise, the screen flips to you when you make a noise, and it can be a little bit distracting. And then also, please chat your questions, and I will work them into the conversation as many as I can. So you don't have to wait for the Q&A at the end, but we will have a time after we get through the introductions for questions towards the end. But feel free to chat them anytime, and we'll work them into the conversation. So joining me today are Gretchen Wortman, Vice President for Policy and Programs at the National Minority Quality Forum. Gretchen brings more than 30 years of experience in health policy analysis, strategic planning, and program design and administration. She's held key positions in both the public and private sectors, including at the U.S. Department of Health and Human Services, the Missouri Department of Health, and the Comprehensive Health Planning Council of Southwestern Michigan, the Greater Detroit Area Health Council, and the City of Detroit Department of Health. Also joining me today are Douglas Holtz-Aiken, President of the American Action Forum. Doug served in a variety of influential policy positions, including Chief Economist of the President's Council of Economic Advisors and the 6th Director of the Nonpartisan Congressional Budget Office, or CBO, which provides budgetary and policy analysis to the U.S. Congress. He also served as Director of Domestic and Economic Policy for John McCain's presidential campaign. And also we have Michael Ward, Vice President of Public Policy for the Alliance for Aging Research. Michael has more than a decade of experience advancing healthcare innovation through policy research, federal advocacy, and partnership development. I've asked our panelists to provide an opening statement, and following that, I'll lead the discussion with our 3 guests, and then we'll field questions submitted by our audience. If you want to ask a question, like I mentioned earlier, please type it into the chat, and I'll work it into our conversation. I'd also like to thank the Applied Policy team for all their support in making these possible and all their work to advertise it and make it so that you found out about it. So without further ado, let me turn it over to Gretchen. Gretchen, can you tell us a little bit about the National Minority Quality Forum and your thoughts on Medicare Part D?
Thank you. Can you hear me? Okay. And I'd like to thank the Northern Virginia Health Policy Forum, and my colleague, Michael Ward, for inviting me to address this important group. And I do have to take a moment to correct my introduction. I was with the Comprehensive Health Planning Council of Southeastern Michigan in Michigan. And I'm saying that because people in Southeastern Michigan are really sensitive about that. So I need to clarify
My
that.
apologies.
No, it's okay. It's just that if I didn't correct it, then, I have family and friends who email me. My remarks this morning are actually are more encompassing than Medicare or Medicare Part D or even public sector insurance. For those of us who are not familiar with us, the National Minority Quality Forum is a nonpartisan, not-for-profit research and advocacy organization based in Washington, D.C. Our capabilities include data analytics, policy analysis and advocacy, issue-specific alliance development, and community-based provider quality improvement initiatives. The mission of the forum is to reduce patient risk by assuring optimal care for all. The forum's vision is an American health services research delivery and financing system whose operating principle is to reduce patient risk for amenable morbidity and mortality while improving quality of life. Accordingly, our programmatic and advocacy priorities promote research designs that assure the statistically significant inclusion of all affected population cohorts, a policy and regulatory framework that is responsive to patient needs and preferences and provides clinicians with maximum flexibility, the publication of data analyses that identify diagnosis and treatment patterns within and across geographic areas and population cohorts, and last but perhaps most importantly, enhanced transparency through the analysis and evaluation of the outcomes associated with promulgated policy and regulation. Corresponding initiatives of the NMQF's Institute for Equity in Health Policy and Practice, of which I am also director, include developing metrics of patient risk that are relevant to the three stakeholder sectors, including research, delivery, and financing. Exploring solutions to the methodological and algorithmic biases that create or perpetuate inequities in academic and clinical research. Reviewing and documenting current laws, policies, and rules in the public and private sectors that may serve to redress or reinforce inequities. And evaluating all economic incentives to ensure that they do not create, perpetuate, or increase inequities in healthcare quality and outcomes. As I was reviewing my remarks this morning, or shall I say, as I made the mistake of reviewing my prepared remarks this morning, I realized that I was not clearly communicating to this group what I understand to be the dynamic tension between the ability of this compound complex system of care that we've created in the United States and its ability to serve the interests of patients, families, and communities, and the tension between that and our concerns that the current system infrastructure and the processes and imperatives that power it do not assign value to sustaining the lives of the entirety of our diverse American general population. The past 18 months have highlighted inequities and inadequacies in the American health services research delivery and financing system in the disturbing context of the novel coronavirus. The heightened visibility of these systemic inequities, including the almost time-warping reality of the collision between the public health system and the clinical care system, has increased the potential to harness political and economic will to effectuate long overdue structural change. A critical function of the National Minority Quality Forum is our capacity to collect, analyze, and publish data Our analyses enable us to predict preventable or amenable morbidity and mortality associated with chronic and acute conditions, including but not limited to influenza, pregnancy outcomes, COVID-19, hepatitis, cancers, and autoimmune diseases. Our analyses can also predict continuing and exacerbated outcomes of care that are compromised by the legal, regulatory, and payment policies that contextualize the behavior of both the public and private sectors. When viewed through the lens of the immediacy of the ongoing carnage of the American COVID-19 epidemic, the option for change becomes an imperative for change that can no longer be ignored. So, as is also so distressingly true, concomitantly experienced suffering and the awareness of shared burden for the solutions enhance the opportunity to harness the political and economic will to effectuate sustainable systemic change. Therefore, I believe that we are presented with what is quite possibly a once-in-a-century opportunity to assure that health sector-specific business imperatives are aligned with the needs of the healthcare consumers whose dollars and needs power that system. It is the manner in which those changes are constructed, are designed, implemented, and continuously evaluated that must be planned and managed with intention and foresight. Our time is short, and clearly my concerns are wide and deep. Therefore, I will end with the following. We believe it is possible for the business objectives of commercial and public interests to coexist with and support the principles of health equity. We also believe that given projected changes in the size and demographics of our diverse general population, operationalizing the principles of equity will significantly enhance the return on investment of all industry and market sectors. I believe that a failure of the public and private sectors to enable realignment of their research and marketing processes with the realities of the market demographics of the 21st century and beyond will have a seismic effect on the profitability and/or viability of a component of our global society that is essential to the survival of us all. The National Minority Quality Forum, through the Institute for Equity in Health Policy and Practice, looks forward to strengthening our partnership with the Policy Forum and its organizational members. I look forward to responding to any questions you may have. Thank you.
Thank you, Gretchen. There's a lot to unpack there, and we'll get to more of that. But let's turn to Doug Holtz-Aiken. Doug, your opening statement.
Thanks, Jim. Thanks, everybody, for joining us today, and I appreciate the Northern Virginia Health Policy Forum for the invitation. I love to talk about Medicare Part D. I was at the White House when it was just a gleam in some people's eyes. I was at the Congressional Budget Office when it was passed into law, and I've followed it as our best performing entitlement program in the years since. And I think we are at a very unique point because right now, proposals to redesign the basic benefit in Part D really are the sweet spot in policy and politics of the drug pricing debate. A redesign, and I'm going to lean heavily here on the work of my colleague, Tara O'Neill Hayes, who has proposed a couple of redesigns and done some nice analysis of them. The redesign has the opportunity to do the following simultaneously. Number one, it can protect beneficiaries by finally establishing an out-of-pocket maximum and a catastrophic limit on their exposure to costs. I think that's long overdue and something that ought to be a top priority. The second thing it can do is it can protect the taxpayer. In the years since the launch of Part D, increasingly taxpayer dollars have been shifted from subsidizing premiums, which is where they originally were focused, into covering the catastrophic costs up for very expensive patients. And that's been the most rapidly growing part of the program for Medicare. So to redesign it and have a cap on how much the taxpayer has to pay, 20%, and putting the liability for the remainder, not on taxpayer, not on beneficiaries, but on plans and prescription drug manufacturers, gives a combined incentive for those plans and manufacturers to keep the costs of prescription drugs down so they don't end up with that liability, and to keep people from hitting the catastrophic maximum. Those incentives, in turn, reinforce the original market forces that were the important part of the Part D design. The Part D design relied on tough competition between prescription drug plans and manufacturers, the use of formularies and PBMs to effectuate those negotiations, and to get low-cost drugs wherever possible into the program. And indeed, it's often noted that the plan has come in well below what we originally estimated at the Congressional Budget Office at its launch. And that wasn't because generics showed up that we didn't expect. We had a pretty good feel for the pipeline at the time of the launch, but it turned out that those market forces were very powerful, and there was greater utilization of generics and greater negotiating effectiveness on the part of those plans through their formularies. And so I think it's a good idea to enhance those market forces that were in the original design. We've slipped a little bit away from them since, go back and firm them up. And in the process, we may get benefits that spill over into the larger drug pricing debate. Medicare Part D is about a quarter of national drug spend, and everything you can do to improve drug pricing through Part D, we ought to try to do, because everything that protects the taxpayers, the beneficiaries, and improves those market incentives is also of bipartisan support. One of the few places that you can find in the politics of drug pricing right now is that the Trump administration's budget contained a Part D redesign of this type. HR 3, the lead proposal by House Democrats, contained a redesign of this type. Republicans have their own redesign of this type in HR 19. We saw it in the Senate Finance Committee bill in the last Congress. So if there's one thing that we can find some unanimity about, it's redesigning the Part D benefit to enhance protections for beneficiaries, taxpayers, and to improve market incentives. So that's a rare moment in recent policy and politics. I think we ought to take advantage of it. And my hope is that that's one thing that we will see in the remainder of this Congress. So Jim, thank you for the chance to be here today. Look forward to the conversation.
Thank you, Doug. And let's go to Michael. Can you tell us a little bit about the Alliance for Aging Research and a little bit about its interest in Medicare Part D?
Absolutely, and thank you, Jim, and thanks for the whole Northern Virginia Health Policy Forum team for putting this event together. As Jim mentioned, I'm the Vice President of Public Policy with the Alliance for Aging Research. The Alliance was started in 1986 with the mission of advancing research and working to ensure that those findings were applied to improve the health and lives of older adults. Our work is multifaceted, includes award-winning health education awareness campaigns that help individuals understand what changes are normal and which ones are not as they age. On the policy side, we've helped to usher in increased funding for age-related research at the NIH, served as a patient voice within the FDA's drug development process, and worked with the CMS to ensure that care delivery results in better outcomes for the aging population. As Jim mentioned, we've just celebrated the 56th anniversary of the Medicare program. And as always, debates continue on the scope of federal health benefits. As with any federal program, there are groups who believe that the benefits do not provide sufficient coverage to meet population's needs, while others are concerned with growing programmatic costs and sustainability. However, in regard to the Medicare Part D benefit, there is consensus. Patients face too much exposure to out-of-pocket costs for prescription drugs. These costs are not a trivial thing. They impact not only wallets, but health outcomes. When faced with large out-of-pocket expenses, patients may face difficult choices between paying for medication or other life expenses, which can then lead to abandoned prescriptions, skipping or only taking partial doses, and non-compliance with medication regimens. This non-compliance can result in costs in the form of expensive hospitalizations and medical complications. Indeed, research from Amitabh Chandra and others released in February of this year showed that a random increase of 33% in out-of-pocket price, equal to an average of $10.40 for a drug, caused a 23% drop in total drug consumption and 32.7% increase in monthly mortality. The study connected the mortality effect to cutbacks in life-saving medications like statins and antihypertensives, for which clinical trials show large mortality benefits. Importantly, these patterns existed irrespective of socioeconomic circumstance. So coverage for prescription drugs has long been an issue, though Medicare has operated since 1965. As Doug mentioned, the prescription drug benefit was not passed until 2003, and coverage did not begin until 2006. Since then, there were concerns around the coverage gap, or known as the donut hole, which then the ACA, the Affordable Care Act, closed over the following decade. But still, Part D includes unique features that's not really found in other types of insurance plans. I'll note a couple of factors. The first being the lack of an annual out-of-pocket limit for beneficiaries, which is a feature that's practically universal to other types of medical insurance. In 2021, when patients hit $6,550 in out-of-pocket costs, they enter the catastrophic phase and therefore only pay 5% of cost. However, there's no set limit on out-of-pocket costs, and already if a patient's spending over $6,000 in out-of-pocket costs, that's very significant. Secondly, this is more of a market piece, but premiums in the Part D program have remained stable or have actually declined over the last decade. There have been changes to the Part D benefit that have reduced plan liability, including an increase in the manufacturer coverage gap price discount on brand name drugs from 50% to 70% in 2019, which led to a reduction in plan liability. At the same time, low premiums in the program have been generally prioritized at the cost of higher co-insurance rates, which really certainly impacts patients that do have costs that are beyond de minimis amounts. So what do we do to address the challenges beneficiaries face at the pharmacy counter? The first solution is pretty straightforward. Part D needs an annual limit on out-of-pocket expenditures. Broadly, I'll say Congress understands this, and if a prescription drug bill does indeed pass, it's likely to include this reform. So that's the cap, which is a good first step. Recent surveys show that on average, beneficiaries have difficulty in affording more than $200 in drug costs per month. However, this is an average, and some individuals are challenged by much lower amounts. A maximum liability limit is critical to limit overall costs, but it doesn't address all issues, nor does it address the seasonality of expenses that lead to higher costs early in the year. Patients, especially when their benefits reset, would continue to face affordability challenges if we pass only a cap. If we don't actively address these issues, then beneficiaries will still feel acute cost pressure that will lead to noncompliance and the negative impacts that I discussed earlier. So we need a policy to pair with a cap to help address the ability for beneficiaries to pay for medications before they hit that annual limit. I'll outline a couple of potential options, one that has gained general buy-in from Congress, and another that CMS has tested through the senior savings model. In most comprehensive congressional proposals, cost smoothing has been included with a cap. So cost smoothing would allow beneficiaries to pay their accumulated out-of-pocket cost in installments, typically over the course of a plan year. So this is a highly simplified example, but if a beneficiary accrues $1,200 in out-of-pocket expenses in January, they could pay $100 at the point of sale and then $100 each month the rest of the year. However, it is important to note that smoothing needs to be made available to beneficiaries early in the benefit year, something that is not guaranteed or even likely under some of the most prominent drug pricing proposals. Another consideration is a flat copay, which CMS has been testing in the senior savings model for beneficiaries with diabetes, which caps the cost for insulin at $35 throughout the benefit year, without a corresponding reduction in the manufacturer discount contribution. An expansion of a flat copay policy while allowing for formularies under a flat copay maximum could introduce some much needed simplicity to the benefit while lowering costs for the majority of beneficiaries. So I mentioned there are a few major proposals in Congress, first being HR 3 proposed by House Democratic leadership, HR 19, the Republican counterproposal to HR 3, and then the Prescription Drug Pricing Reduction Act, also known as Grassley-Wyden. These bills were all introduced during the previous Congress. HR 3 and HR 19 were introduced with minimal changes earlier this year, and the Grassley-Wyden package is being used as a starting point for a revised Wyden proposal that is expected to incorporate some type of Medicare price negotiation. So HR3 has the lowest cap at $2,000, but has the most restrictive smoothing proposal that only permits qualification if a beneficiary's first fill is equal to or exceeds $2,000. Unfortunately, this smoothing mechanism would not provide additional flexibility to many beneficiaries. Both HR 19 and the Grassley Wyden package started with $3,100 caps, with smoothing thresholds set at 30 to 100% of the cap. This means that if the Secretary set the threshold at 30%, beneficiaries would need to spend a little bit more than $900 before the ability to pay installments would kick in. I'll also note a proposal from Senators Cassie and Menendez that introduced 2 novel changes to smoothing that was released just last month, including making the flexibility opt out rather than opt in, effectively making it an auto enrollment flexibility rather than requiring proactive action. And then basing qualification for smoothing on a projected spend basis rather than requiring beneficiaries to spend a fixed amount before being able to utilize payment installments. For example, if the threshold is set at 50% of a $3,100 cap and a patient spends $150 out of pocket in January, they would qualify for smoothing at that point rather than not qualifying until October. So while these bills are under consideration, certainly there's corresponding pressure to create pay-fors. And there are changes, including, an inflationary cap to limit the rate of annual price increases, absent justification that merit exploration in terms of benefit to beneficiaries in the Medicare program. At the same time, the big ticket offset being considered by many Democrats involves Medicare price negotiation, or in the case of HR3, price ceilings based on an average of prices in other countries. As Congress develops and considers proposals, I do want to mention a potential problematic inclusion of the quality adjusted life year, known as the QALY. Quality-based value assessment presents negative and unintentional consequences for older and disabled populations, the very 2 populations served by the Medicare program. As individuals grow older, the quality methodology relies on 2 value judgments that fundamentally undervalue the lives of older adults. The first assumption is that older adults have fewer life years left, so by default, drugs and devices that cure or lessen the effect of conditions that disproportionately impact older adults have a lower potential value. The second assumption resides in the quality 0 to 1 scale, where 0 equates to death and 1 means a year in perfect health. For adults that are 80 and older, under qualities, there is no way to be in perfect health. Simply by virtue of your age, you are automatically given a maximum value of 0.8, even if you have no other comorbidities. The devil is in the details, but the unintended consequences of these details are unmistakable. The end result is that if a group is sicker, older, and/or disabled, their value is less. The Institute for Clinical and Economic Review, or ICER, which is the leading developer of quality-based value assessment in the US, largely claims that qualities are a neutral calculation, or in the words of Sergeant Joe Friday, a just the facts analysis. However, any cost assessment methodology is subject to the assumptions and factors one chooses to include. And ICER's value calculations tend to be payer-centric and exclude important considerations such as the impact on caregivers' productivity, societal impact, and equity concerns. Given these clear implications, policies that rely on qualities or quality derivative metrics such as the equal value of life years gained, known as EVLYG, should be prohibited, not embraced. So the impact of affordability-related provisions in prescription drug legislation has been on the periphery, I think, of the public discussion of drug pricing debate on Capitol Hill, either due to the well-understood challenges patients face or a conflation of programmatic cost and the cost to the patient. I think this is unfortunate. And at the same time, what has been completely missing in the discussion around prescription drug costs are the roles that stakeholders at every step between drug development to a patient taking a medication has in reducing costs. As Doug mentioned, it's important to ensure that incentives for manufacturers, payers, and providers support high-value care. For example, between 2007 and 2017, among enrollees without Part D's low-income subsidy, the share of basic benefit costs for which plan sponsors were responsible declined from 53% to 29%. While not easy politically, a holistic approach to reducing drug costs must involve addressing incentives throughout the ecosystem. Manufacturers have control over list prices, but that's just one piece of the puzzle. Pharmacy benefit managers charge manufacturers fees for preferred formulary placement and negotiate preferred acquisition rates. The savings from these negotiations create financial gains for PBMs and shared gains with insurers and employers. At the same time, costs associated with these arrangements could be incorporated into list prices. Medicare Part B, care providers by law receive an add-on payment, which is equal to the average sales price plus 6% For administration, that due to its structure as a percentage of ASP may incentivize prescribing practices. Addressing the ASP issue will grow in importance as precision medicine and additional biologics, which are likely to have immense clinical benefit, but increased manufacturing complexity and costs come onto the market. Other drug pricing programs like the 340B program are well-intentioned, but need reform to ensure the benefit is well-targeted and to prevent program abuse. So fixing prescription drug pricing costs cannot be done well without addressing systemic issues. Stakeholders at each step of the path have a role to play in addressing these costs for patients in the Medicare program. So I'll hand it back to you, Jim. Look forward to discussion.
Thank you very much, Michael. So let's move back to Doug. So before we get into the details of Medicare Part D, since you were there, and I think it was our first interaction when I worked in the Senate Legislative Council drafting Medicare Part D, and you were over at CBO scoring it. And I was thinking, since we have some folks outside the Beltway, that some of these words might be a little bit of jargon. Could you explain a little bit about, what CBO does? Why do they, what is a score, and why do they score legislation, and why does that matter? And then we'll go into, how we balance the other objectives.
Sure. The Congressional Budget Office was created by the Budget Act of 1974 to support the Congress in budgetary affairs. In the aftermath of a fight with then President Nixon, the Congress decided they couldn't rely on what is now the Office of Management and Budget for all their budgetary information, that they wanted to play on equal footing. And to do that, they set up the CBO to generate policy analysis and advice, in particular, what tax revenue would come in and what spending would go out of the Treasury as the result of legislating in various ways. And secondly, they set up a process known as the budget resolution for doing budgetary planning. And in principle, Congress doesn't actually do anything by the books, but in principle, House passes a budget resolution, which is just a plan for spending, taxes, and borrowing. Senate passes a budget resolution for a plan. They get to an agreement on it, and that governs the actions of the appropriators on spending each year, on the authorizing committees, in this case, Senate Finance, Ways and Means, in particular on what goes on in mandatory spending entitlement programs, and then the tax committees to raise revenue. So at the birth of the Congressional Budget Office, there was an agreement with the White House that they could spend no more than $400 billion over 10 years on a prescription drug program for seniors, what became Medicare Modernization Act and Medicare Part D. The Congressional Budget Office at every point would take proposed legislation, whether it was early in the process, confidentially as they developed the design, or later when there was a formal proposal which was being amended on the floor, and it would score that legislation. That is, answer the question, how much will come into the federal treasury through premium payments in particular, and how much will go out in terms of subsidies for premiums from taxpayers and other outlays to set up the program, things like that. So the CBO is always just running the numbers. But to do that, it had to imagine the workings of the market for an insurance product for the financial cost of outpatient prescription drugs, what the take up for that product would be, how many seniors would sign up, what the insured spend would be under that program, how much would the prescription drug plans be liable for. As a result, what the premiums would have to be, since we're going to charge actuarially fair premiums that would stand up to scrutiny, and then what the subsidies would be, because you had to 75% subsidize the program through taxpayers. So CBO was trying to do an enormous job of imagining this product, which did not exist in nature, what it would look like, who would use it, who would provide it, who would generate the drugs consumed under it, and what the taxpayers would be on the liability for paying in that program. So it was an enormous intellectual undertaking, to be honest. It went on for years before it was finally passed, and a lot of effort was put into understanding what it might look like. A lot of expertise, much of which is probably on this call someplace, was provided to CBO to aid it in doing that. We got information from all of the pharmaceutical companies about their R&D plans and where they were in development, so that we knew what new expensive drugs might be hitting the market, what was going off patent and be subject to generic competition. We had a lot of information, but as I said, it's come in about 25% below what we expected. And that's been due to, I think, the power of the design. People have always talked a lot about the costs, either beneficiary or taxpayer, or budget, whatever. And I think have forgotten the fact that this was a very unique policy design that relied heavily on this tough negotiation between plans and manufacturers. And that was something that was built into your design, and the CBO took seriously in trying to do the analysis.
So I guess, could you go into a little bit more about the what interests was the Medicare Part D program trying to balance, and how did it achieve that? And specifically, I'm thinking that Congress enacted a catastrophic coverage benefit in 1988 that didn't go very well. But there was widespread agreement that seniors needed protection against high drug costs. So in the 1988 legislation, they had only a catastrophic benefit. Could you talk a little bit about what Medicare Part D did different, and how it decided to do that to achieve the $400 billion CBO score goal relative to getting beneficiaries needed coverage for prescription drugs?
So there's a big balancing act that went on from different policy objectives and then, frankly, political objectives. So first and foremost, there had finally had arrived the recognition that pharmaceuticals are part of modern medicine, and that it was completely irrational to have a Medicare program that covered inpatient care and covered some outpatient care, but left out outpatient prescription drugs. And so this was first and foremost doing the right thing by seniors so that they got the care that was appropriate for that day and age. Second thing that happened was that Congress was very cognizant of this issue of the 1 year survival of that catastrophic question. People differ on why it failed after a year, but in the end, seniors loved getting the catastrophic maximum, didn't like paying for it. And so there was lots of concern about what this would cost seniors. And that influenced the Part D benefit design in two really important ways. First, since they'd agreed on $400 billion over 10 years, I mean, they had a budget constraint on the congressional side. They couldn't cover everything they wanted to, because if they did, it couldn't be subsidized by the taxpayer, and the seniors would have to pay for it. And so premiums would be higher. And so there was originally this thing, the donut hole that Mike talked about, where you had a standard deductible, and then you had a 25% co-insurance rate for a while. And then the beneficiary was 100% liable for the next couple $1,000. And then there was a catastrophic maximum, after which they were responsible for 5%, but 5% as far as the eye could see. That's a really weird insurance design. Part of it was to keep premiums down. So if you don't cover the donut hole, you don't have to charge premiums for it. And so that's all that was. The second part was they wanted to get healthy people in the pool. There was a terrible concern that you'd only draw the sickest of seniors. And so the upfront, very small deductible region and a 25% co-insurance rate for basically everybody in Medicare was meant to draw into the pool lots and lots of people and get a balanced pool, including the healthy. That's fine, except that it limited their ability to do things at the back end. And to this day, we're dealing with the back end catastrophic costs again and again and again. And that came out of that design. That same design, by the way, you can interpret politically, which is that they just wanted to buy every senior. And so Republicans were politically accused of just trying to buy healthy seniors by giving them their drugs cheaply. And so those went hand in hand. I don't have any illusions about that. But you really did have to get healthy people into the pool. The last piece of it, which is the hardest in advance, was to try to meet consumers' needs in a market way, which is to say, let's have a standard design, but if you want to put out a plan that has a more appealing design for a particular set of seniors, as long as it's actuarially equivalent to the standard design, you're allowed to offer that. And so the idea was to allow lots of competition among plans for both designs and formularies, to attract seniors and have them exercise the power of consumer choice to really drive patient satisfaction. And economists love this. That, I mean, that was how I was trained. That's how markets are supposed to work. There was enormous skepticism about whether that made any sense at all. And a huge chunk of the bill, if you go back and read it, is devoted to quote fallback plans. What are we going to do if the private sector doesn't show up for this benefit? And how are we going to provide seniors in rural areas where no one's going to come in and provide it? And those have never been used. And they were the public option of their day. And the program has proven to be very robust with respect to entry of competition, plan choices. Seniors have dozens of plan choices on average in the United States. Lots of measures, survey measures of satisfaction with the program. Seniors either very happy with the program or happy with the program. So I think it's been a fairly successful design, which doesn't mean it's perfect, and there's still some things that ought to get tuned up, and I think this would be a good time to do it.
Thanks, Doug. So let's go over to Gretchen. Gretchen, in terms of healthcare disparities, what do you think is needed in developing equitable prescription drug access for everybody?
And I'm going to sort of react to Doug's last comment that now's an opportunity to tune up the system to address gaps. And the concern we have is that if you look at the underlying economic models and the predictive analytics that informed the design of the system in the 60s and the modifications over the subsequent decades, to a significant degree, they excluded the costs and needs of populations that are sort of generally categorized as populations who experience disproportionately poor outcomes of care and tend to present with disproportionately poor health status. And so I would say the challenge, I agree with Michael's recommendations regarding out-of-pocket caps and smoothing and some of those other what I'll sort of stopgap, stop loss or protective suggestions for populations who, first of all, survive long enough to become part of the Medicare pool. But we have in our society what I think has become very visible and unignorable, which is that a growing component of the society is excluded from the denominator of all of the research, of all of the numbers, of all of the care that inform solutions moving forward. So I'm not ignoring your question, James. I don't have a Part D specific solution. We at the National Minority Quality Forum have concerns about any central entity negotiating drug prices. We have, I would say, more than a passing concern about the explosion in use of value assessments, regardless of whether, in particular, those that employ qualities or quality-like metrics that assign differential value to the lives of those who are affected. And the problem becomes that we have a system that is structurally and systematically excluding information about populations who have greatest need because of political decisions that resulted in an exacerbation of negative determinants of health. So in the short term, I recommend, we would recommend the smoothing, the out-of-pocket caps, elimination of value assessments that compromise access to new therapies, and then a commitment to what is it, since the 60s. If we start now, based upon what we've learned about how the system that we created works, and also based upon what we've learned about how this system does not work, to begin the design of one that is more responsive to the entirety of the population, that was not considered to be the center of the bell, was not in the center of the bell when this system was designed.
Thank you, Gretchen.
Thank you.
So let's go back to Michael. Michael, in her opening remarks, I'm not going to say it as artfully as Gretchen did, but essentially one of her points, I think, was that consumer dollars and needs are really what's behind the system. And so as far as consumer dollars, and Doug also pointed out, one of the key balancing characteristics of Medicare Part D was how much can seniors afford, so that they would, sort of accept the new program. I was wondering, from your point of view, are there any data or anything like that research that could show how much seniors could reasonably afford?
Yeah, I mean, there's the information I shared a little bit earlier about, Medicare beneficiaries, folks over 65, having difficulty affording more than $200 a month. I mean, that is not a monolith. That is an average, I think, to, some folks can afford more, but there is a significant population that can afford far less. And so I think that's part of the nuance of this conversation and discussions I've had on Capitol Hill as well. I think there's within Part D, there's a low income subsidy program, for lower income individuals. And that's been critical. It's been helpful and certainly support, increasing the number of beneficiaries that would apply, that would qualify for that. However, I think, in terms of this, when I talk to folks about the smoothing mechanism, I think there's an assumption that, folks have more money, and so, we don't need to worry about affordability for them as much. We don't need to worry about, we don't need to consider the impacts as much. And, I would point to the study that I shared and, in my remarks, that there is a real impact on mortality and outcomes that happens whenever patients see higher out-of-pocket costs, no matter what their income bracket is. So yes, we need to protect, our, beneficiaries that are of lower income. I think that's essential. However, we can't ignore the health impacts and the evidence that's showing that there are negative health impacts on beneficiaries throughout the Part D program, because those costs show up elsewhere, if we're not addressing affordability for them as well.
So Jim, can I say a word about that?
Yes.
So who pays more and how, I think, is a really important part of the sort of political economy of what's gone on. I'll give you, 3 examples. First, the design, the original design really reflected this deep concern about premiums, and they can't be too high, and it's got to be kept low. Secondly, in for example, our redesign, we would cover so much more of the out-of-pockets that most people face, and with the catastrophic maximum, there's going to be a select few Medicare beneficiaries who are going to be vastly better off under that redesign. It is true, however, that premiums would go up for some others. And so if you have zero drug costs and premiums are higher, you're worse off. And any number of people told us that that's a non-starter. Premiums just can't go up. So you have the situation where a tiny premium increase for a vast number of people stops the catastrophic expenses of a select few. That's getting the insurance design exactly backwards. Like it should be that a tiny little thing covers the costs of a few people, because that's the point of insurance, spreading those costs across the population. And the same thing came up with the rebate rule proposed under the Trump administration. Premiums went up and that was a non-starter. So I think as a matter of getting the policy to be good politics, there has to be some re-education of what constitutes premium versus total out-of-pocket costs, and making sure that the total out-of-pocket is distributed appropriately, not just the premiums.
And I'll piggyback on that as well. I mean, it's been a couple of years ago, but we the Alliance did some research, did a survey showing that over half of seniors 65 and older would be willing to pay a few extra dollars a month in premium, between $4 to $8 more, to have I guess just to have stability in their costs throughout the year, whether it's through a cap or other affordability recommended mechanisms. So I think the ability for people to be able to know what their costs are going to be and know that they're going to be sustainable for them throughout the year. I think to Doug's point, people would be willing to pay maybe a few more dollars, and when you spread that among a large pool of beneficiaries, that can go a long way.
I think I would just like to comment, not specifically on Part D or Doug's or Michael's comments, but in conversations that I have to which I'm invited, there's lots of conversation about health illiteracy, health system illiteracy, the ability of the consumer to understand the benefits, the insurance package. If you look at it through the lens of the physicians want us to, I think, simply understand enough so that we can do what he or she tells me to do. Okay, but we've got a system that is actually it's incomprehensible, it's undefinable or has not been described and defined in a manner that is consumable by those who are not responsible for a particular sector. And as I was thinking about my remarks, and I will admit to having a little anxiety about being on a panel with Doug Holtz-Eakin, well, it's true. The mental image of a Rube Goldberg contraption came to mind. And we have a system that has become so compound and complex to generate for me as a consumer, a particular outcome of that system, that it is difficult to rationalize for those of us who were not sort of the essential architects. But the other problem is every single twist and turn of that contraption has to generate a profit, is a business sector in and of itself. And as we continue to work to refine that system within which we currently live and function, and I think we need to continue to do that, and the National Minority Equality Forum does that. But what we also need to start having is some conversation about not where we started and what we meant to do, but what we have now and whether the manner in which it is structured is the most efficient for the output and the most cost-effective for, yes, those consumers for whom we are told the system exists. And so we're going to have to run parallel tracks on this and have both conversations. If we're lucky, there are only two, but there aren't, as we move forward, because it's becoming clear, and I'm going to go back to the fact that most of the conversations we've all been engaged in the last year have been framed by the COVID-19 experience, just because it was so real Okay, so tangible for everyone, including those who thought they were protected by virtue of their education or their income or the geography within which they reside. So I'm going to encourage that yes, we continue to find ways to refine the system we currently have, but there has to be a reassessment of whether going forward, because 150 years, 200 years is not a long time in drug development, in the evolution of an economic system or of society. We have to start rethinking how we take what we now know to be how systems can work or should work, and redesign something for the future.
Thank you. And I've been a fan of the National Minority Quality Forum for a long time, and Dr. Puckrin. And I've really been impressed with how the National Minority Quality Forum uses data to highlight the disparities. So it's not a emotional feeling or anything like that. It's just look at the map and we can show you where there's disparities. Now let's come up with a plan to address them. And I was really encouraged by the HHS, Office of Minority Health, and CMS did a study on arthritis and disparities and posted it on their website, coming from the official agency, showing a map of health inequities amongst people suffering from arthritis, both osteoarthritis and rheumatoid arthritis. And I think that kind of data was largely created by Gary's vision, because the map looks just like what Gary had been doing for years before CMS put one up in 2020. So thank you for that and for the contribution in making health disparities more addressable by putting some facts and data around them. And then we're almost out of time, but we did get a question that I thought was pretty compelling. So I'm going to ask each of you to offer a final thought, but I'll also put the question out there. Pharmaceutical manufacturers have long stated that the drug prices are high to fund research and innovation. And so you basically have to, you try a lot of times and you spend a lot of money trying to, do phase 1, phase 2, and phase 3 trials of drugs that never get to market. Then you finally have one that you get to market, and then the price of everything has to roll up into that one successful product to drive further innovation. So now there's a lot of news about high drug prices and negotiation to bring prices down. In your final remarks, if you do have thoughts on a balance between innovation and reducing the cost of drugs, feel free to add that. But let me go to Michael first with his final thought.
Yeah, I think it's a complex issue, and I'll say that I think that there's definitely work that could be done in the clinical trial process to streamline it, to make that process less expensive, frankly. That way, the development, both the failures and the successes are less costly. Second, I think I'll just quickly note that I think part of the emotional appeal that people talk about, we talk about prices in other countries and in Europe, and I think naturally we're like, well, why are we paying more as Americans? And I think and talks with House leadership, they say, well, European countries, OECD countries are not paying their fair share. And I would humbly submit that that their approach wouldn't necessarily address that concern. I think there is some work that can be done on the trade front to help balance out those inequities, make sure that the global community is supporting these R&D costs rather than just Americans. And I'll leave it there and let Doug weigh in.
So once again, thanks for the chance to join this conversation. Certainly, if you look at the US versus other countries, one of the striking facts is that the price European consumers pay for the regime they've supported is that they don't get a lot of drugs, and they certainly don't get them in a timely fashion. And so you can pay in a financial sense, or you can pay in an access sense, but you've got to recognize the trade-off you're making. And we're struggling with that trade-off in the US. One of the reasons I support the Part D redesign so fervently is that I want to give market forces every chance they have to work in the area of drug development and distribution. And if we find ourselves unsatisfied, we're going to have to come to the understanding that when you develop something that cures an infant's muscle disorder, and the population is 7 people every year, and it costs $1 million, that $7 million can't be visited on those families, and that's not an equitable distribution of those costs. And we'll have to find a way to socialize, whether it's through an insurance product or the government budget or something, those costs. So let the market do everything you can to keep the production and distribution costs as low as possible, but recognize that's not going to solve all your problems. And we haven't really come to terms with that in the US.
Thanks, Doug. Gretchen, your final thoughts?
Well, I would say that every sector, whether it's the pharmaceutical manufacturing sector or plans or clinicians, the provider sector, should be challenged and are challenged to defend excessive costs in their business models. And all are able to do that, and finding the kernel of truth and in those rationales is part of the challenge. I think that is can be informed by more transparency regarding the inputs to those calculations. So absolutely, prescription drug prices are an issue, but as is every other issue. But I think that we also need to remember that the consumer buying power, the patient buying power, is one of those market forces. And I would say on some level is the most important market force if, and as Gary Puckrin always reminds me, it's all our money anyway. Now you can take issue with that. But for those of us who get our benefits through our employer-sponsored plans, it's part of our compensation. For others, whether they're part of employer-sponsored plans or other components of costs, we're paying for it through tax dollars, or we're paying through copays, or we're paying for it for over-the-counter drugs. So the consumer needs to have a better sense of the leverage that we have and the manner in which all costs associated with this system are experienced by us, not just the out-of-pocket costs, although the out-of-pocket costs are an issue. And so I will stop there. So I think transparency, consumer market education, and factor that in as we move forward to redesigning the system for the 22nd century.
Thank you very much. And this was a fascinating discussion. I could talk with you all day, and we could have much longer than an hour and still be really interesting. But I try to keep these things to lunchtime so people will come and be able to get back to work on making these things. But I know the three of you, the information you've shared today has enriched our audience, both personally and professionally. So I thank you for that. We'll have another forum in September, and I'd like to thank the Applied Policy Team, the Alliance for Aging Research, the American Action Forum, and the National Minority Quality Forum for their time and expertise today. So thank you all, and have a great day.